Okay, good morning, everybody, and welcome to this session on novel technologies and strategies. My name is Jonathan Lederman. It's a pleasure for me to chair the session. My co-chair, Dr. Asima Mukhopadhyay. We've got some very interesting speakers this morning. We'd like to ask the speakers to speak for about 15 minutes, and then we'll have time at the end for you to ask questions. So without more ado, I would like to welcome our first speaker, who's Professor Ahmed from Oxford, who's going to talk about vaccine therapy for preventing ovarian cancer.
Well, thank you very much for the invitation for me to talk today. I'm going to give you a little bit of background first about how we started working on the idea of starting a vaccine for ovarian cancer, and then show you some of the unpublished data that prompted the idea of vaccination and immunization to prevent ovarian cancer, and then just talk briefly about the steps we are taking at the moment to develop the vaccine. So Ronnie is here, and just sitting in front of me here, and I'm going to make a confession. When this idea started that that the ovarian cancer comes from the fallopian tube, I didn't buy it at the time. I didn't buy it, I have to confess. And I start just looking at the data, thinking about it. I mean, you all know about it now. So until we actually started doing experiments that had nothing to do with fallopian tube origin, ovarian cancer whatsoever, and then started sort of pointing to the direction of the fallopian tube as being the origin. So I converted completely to thinking that definitely the fallopian tube, from my perspective, is the origin. So I'm going to share with you one important milestone in our journey in the lab to believe that the fallopian tube is the origin. So we started that by, in fact, many years back by sequencing metastatic tumors, whole genome sequencing of 33 metastatic tumors from various sites inside the abdominal cavity. And that essentially pointed to a mutation outside the coding region that essentially was inhibiting the expression of SOX2. And when that mutation, in that point in the genome, upstream of SOX2, when you have a mutation, then SOX2 starts going up. And when we looked at fallopian tubes, we found that the fallopian tube cells are highly enriched in SOX2 expressing cells. And we did a lot of validation for this finding. And that really just started me thinking that it is, the fallopian tube is a credible site of origin. But then we did this exercise a few years back. We did single-cell sequencing of the fallopian tube using a single-cell RNA sequencing. And what we found was, in addition to ciliated cells, we found 4 additional subtypes of non-ciliated cells that we didn't previously know. And when we looked at the genes that differentiate the different subtypes, we drew about 52 genes. If you knew the expression of these genes, you could separate these 5 different subtypes. Let me show you so if you check the 52 gene expression, you can separate the ciliated, the cell cycle, EMT, keratin 17, and differentiated, 5 different subtypes. But what was really interesting is then when you took these bulk RNA sequencing of tumors, you ask the question, are we able to see these subtypes in established ovarian cancers? And the answer was yes. So you take published RNA-seq data and look at these 52 genes that differentiate the normal fallopian tube cell subtypes, and look at their expression in the tumor and try to get a score for each of these 5 subtypes. And what we found was that the EMT score of this subtype, of this classification, which we call the Oxford classification, correlated highly reproducibly with prognosis, regardless of stage of disease, performance status, all the usual prognostic factors. So this was really astonishing for me, because I did my PhD on trying to find prognostic signatures for ovarian cancer, and it was really difficult. Every time we found a signature, we could validate it in 1 or 2 cohorts, and then it breaks down in the next cohort. This was so reproducible. I didn't see anything like this before. Even if it comes from my own lab, I'm sort of bragging a bit about it, but because it is really reproducible. We've now tested it in about 15 independent cohorts, and every time we find that the EMT score that was derived by testing gene expression of 52 genes that essentially differentiate the different subtypes of the normal fallopian tube. So this to me indicated that there is a strong link between the fallopian tube cells and the tumor, supporting the idea of the origin of ovarian cancer being coming from the fallopian tube. This is our paper that was just accepted, showing again, yet again, that these EMT scores are independently prognostic. Okay, so that's how we started with the ideas of the fallopian tube as the origin. So then we asked the question, we all observe this. See patients with metastatic ovarian cancer. If you look at their fallopian tube, you see a stick, and the stick is only micrometers in diameter. In the same patient, you have an advanced metastatic invasive tumor in the abdomen, and in the same patient, you see a seamless stick. And we ask the question, why is this? Why is these tumors in the fallopian tube not invasive and destructive? And we started hypothesizing that it is to do with tissue-resident memory cells, a subclass of immune cells. They are T cells, so these are the subtypes of immune cells that engage in, have killing capacity of cancer cells. And we started hypothesizing that these tissue-resident memory cells in the fallopian tube were effective in constraining the tumor in the fallopian tube, but not doing a great job in the abdominal cavity. So we're still working on this hypothesis, but the first data points that we obtained were really tantalizing for us. So what we started by doing, we thought, okay, if you looked at the T cells in the vicinity of the abdominal cavity, you would expect that a high proportion of these T cells would be tumor-specific, i.e. they're there to fight the tumor, to constrain the tumor. But if you looked anywhere else, in the blood or in fact in the fallopian tube, in the normal fallopian tube, normal-looking fallopian tube in the same patient, you would expect to see non-specific T cells. You wouldn't see similarity in the T cell clones between the tumor and the fallopian tube. So we started to test that. So what we did was that we essentially took samples from metastatic tumors, and extracted single T cells that were CD103 positive. So CD103 is a marker of tissue residency. So we extracted what we believed were tissue-resident memory cells in the tumor, or essentially TILs, tumor tissue lymphocytes, tumor-infiltrating lymphocytes from the tumor. And then went to the fallopian tube, took a strip of the fallopian tube, and then again made single-cell suspensions from that and extracted the CD103 positive fallopian tube T cells. And then did a technique which is called single-cell TCR sequencing. So the T cell receptor is encoded by a sequence of genes, and each receptor on the surface is represented by a unique sequence that only that TCR shape has that one unique sequence. And any number of T cells that has the same sequence essentially came from the same parent. We call them a clone, a T cell clone, because they have identical T cell receptor sequence. Okay, so what we did, we collected about 70,000 cells, single cells, from the tumor and from the fallopian tube from 5 patients. And the fallopian tube looked normal, and histopathologically there were no evidence of stick, and looked entirely normal. And again, I want to remind you that this was from the same patient. And then we looked at the overlap. One wouldn't expect to be very high overlap. In fact, if you compared the tumor single cells to the blood, you would see less than 20% overlap. So these are essentially the cells in the vicinity of tumor are tumor specific. The ones that are circulating are not tumor specific, with the exception of some cells that make it out of the tumor to the bloodstream. But when you look in the similarity between the tumor and the fallopian tube, there was up to 80% overlap between the tumor and the fallopian tube in the top expanded clones. And let me explain that to you. So if you looked at the tumor and you looked at the top expanded clones, the 10 top expanded clones in the tumor, so a clone has the same TCR sequence, okay? So when we say expanded, let's say the cells, the clones that have 1,000 or more members. So those are expanded, and the reason they're expanded, we believe and we think, it's because they are tumor-specific and fighting the tumor. If you took those top clones, you'd find that 80% of those top clones are represented in the normal-looking fallopian tube. And that, to me, was a moment of great belief that the fallopian tube is indeed the origin, because it meant to me that this was essentially a signature of what happened in the past, that these cells, these immune cells that are resident in the fallopian tube, were exposed to the fallopian tube, to the early carcinogenesis in the fallopian tube, and developed this memory for these cells. So the fallopian tube cells that we think are tumor specific are less exhausted. If we look at the exhaustion markers of the identical sequences in between the fallopian tube and the tumor, you see that the fallopian tube cells are less exhausted. They also carry the gene expression pattern of the same gene expression pattern to those that we think are of T cells that we think are tumor specific. But to cut a long story short, what we really did then, what was really important to do, was that we took these T cells from the fallopian tube that have these shared clones, grew them in the lab, and then grew organoids, grew tumor cells from the tumor or from the fallopian tube, and then looked at co-cultured these T cells with either the tumor or the fallopian tube organoids, and we found that these T cells from the fallopian tube reacted to the tumor cells. So the black dots that you are seeing in the co-culture with the tumor organoids are a sign of reactivity. This interferon gamma release means that these T cells have memory to the tumor. We also sequenced the tumor, identified the mutations, and found that if you actually just represent the mutations that are specific in the tumor and you co-culture those representatives of the mutation, peptides that carry the sequence of the mutants, you co-culture those with T cells from the fallopian tube, you stimulate, you see reactivity. So that meant that these T cells, to us, that meant that these T cells were in fact specific for the tumor, that they were most probably initiated and so the tumor cells at the very beginning, at the origin, at transformation. And that meant to us that perhaps if you train these T cells, immunize these T cells with antigens that we believe are specific to ovarian cancer development, these are either mutations or tumor-associated antigens, that if you start stimulating the immune response prior to development, that you may be able to stop formation of the tumor. If you may be able to train these fallopian tube T cells to stop tumor formation at an early stage, or in fact to clear early transformation lesions. So in the next 2-3 slides, I'm just going to show you the steps that we are taking to develop the vaccine. So the first thing was funded by Cancer Research UK. We started this study where we are recruiting 100 healthy volunteers and 40 ovarian cancer patients. Essentially, we're trying to ask the question, are these list of immunogens, list of peptides, neoantigens, tumor-associated antigens, we gathered about 100 of them, are these immunogenic enough? So we take blood cells from volunteers and from patients, and then expose these blood cells to this list, aiming to get a short list that we can then put into a vaccine. We've started doing this, and the results are very, very encouraging indeed. We're really getting immunization of T cells. Then the next step, this is showing you the experimental workflow for how we choose. And we've just, in fact, a couple of days ago, found out that we were also funded by Ovarian Cancer Action to start the work on packaging these neoantigens and tumor-associated antigens using lipid nanoparticles. So we'll start this work soon. The hope is that we would start by doing an injection, a systemic injection, to stimulate an immune response, and then followed by an injection into the cervix to essentially bring this immune response into the uterus and the fallopian tubes. So with that, I'd like to thank you all for listening, and thank our funders, and happy to take any questions if the chairs allow. Thank you.
So we're going to take the questions at the end, and it's my pleasure to introduce our next speaker, Dr. Lisa Barakler from Christie's, and she's going to talk about the novel radiotherapy approaches.
Good morning. Thank you very much for inviting me. I think Alex is in the, and Ranjit. Appreciate the opportunity to discuss the role of and the progress that we've made with radiotherapy techniques which improve precision. So the fundamental principle of radiotherapy is the aim is we want to cure cancer, and I think we're quite good at this mostly. We also treat in the adjuvant and palliative settings, but all this time while we're thinking about the aim of the treatment, we're constantly balancing the concerns about the dose to the organs at risk. So for us in gynecological cancer, this is predominantly bowel, bladder, bone and nerves. And in the words of my very esteemed previous senior colleague, Susan Davidson, she always said, no normal tissue ever benefited from being radiated. So we have made a lot of advancements with precision in radiotherapy, which has helped us to individualize treatments. I'll focus mostly on predictive ones. There are many. Specifically, radiosensitivity. We're well aware that the addition of chemotherapy concurrently with radiotherapy can improve radiosensitivity. There's probably an element of independent cell kill in there as well. But we're also, the hypoxia story, reducing radiation sensitivity is well known, has been around for a long time. But we're still working on it, and currently we're setting up a trial with the injection of hydrogen peroxide into cervical cancers during a course of radiation via the CORTUX study, on the back of the success that there's been with this technique in locally advanced breast cancer. We can also look at oxygen and contrast-enhanced MR scans and with functional imaging to try and see, identify areas of hypoxia. We're combining that with biopsies before and after within the BioCheck study, which is also ongoing. We're aware of the immunomodulatory effect of radiotherapy with the addition of concurrent pembrolizumab by the A18 study. But also we're looking at the effect of the normal tissue microenvironment as well as the tumour microenvironment, and looking at the effect of pelvic radiotherapy on the bowel via our EPRIM study, which is with being run by our gastroenterologist with special interest in pelvic radiation disease. So, but also, another predictive factor is target conformality. So, if we miss the target and the tumour, we're in trouble. So, in gynecological cancers, how can we do this, and what have we done to improve this? Well, so for brachytherapy, this is the ultimate form of radiation, and we have made advancements in terms of applicators and imaging. But the same with external beam radiotherapy, but as well as improvements in image-guided and adaptive treatments, this has all been helped by rapid technological advancements. And then also we can use the role of proton beams. So I'll talk about these for the rest of the talk. So brachytherapy, when I started, we used to insert a metal tube through the cervix into the uterus, do a plain X-ray, do a quick scan check, hadn't perforated the uterus, standard plan, walk away. It was certainly very quick. We then had the introduction of MR-guided radiotherapies with MR-compatible applicators, and you can see, therefore, well, eureka moment, you can see the tumour. But also, if I can get this, we can see where how to target the tumour, but also where we want to avoid the rectum. So we can ensure that the tumour is, the radioactive source can sit at various points. At these red points, can't do this very well, sorry. So we can change the dosimetry, and you'll see the dosimetry lines, which I can't, here, are fairly close, and this is by virtue of the inverse square law, but from radioactivity with a radioactive source. And then on the next slide, but you can also see, well, sometimes we're only treating half the tumour, so we need a bigger sword at this point. So with further applicator development, we can use interstitial brachytherapy with plastic catheters that go through the applicator and through the skin into, and basically skewer the target. And we can be very clever about this with targeting here, but sometimes you just need more, and you just need a machete. And so we have lots where we can place the source in lots and lots of positions within the tumour. Brachytherapy for vaginal cancer is also very similar kind of approaches with applicator, but applicator development we're not quite there. On the left, we've got 3D printed applicators which aren't available certainly to us, but on the right you can see how improved conformality with the use of interstitial brachytherapy can improve the dosimetry. And indeed, we can see that the use of interstitial brachytherapy improves the local control, certainly in cervical cancer, by 10%. So we can conform beautifully with brachytherapy, but can we do this with external beam? Now, certainly we can, and in this case, it shows it nicely with, this is a lady with a stage 2B cervical cancer and also a transplanted pelvic kidney. So, okay, fine. So give it a go. And actually, the planners did an amazing job. The maximum dose to the kidney that we really want to give is 15 Gray, which is the purple isodose, pink. here, and you can see how it wraps itself nicely around the kidney. And also, again, in the coronal plane, avoiding the kidney. And then on the dose volume histogram, oh gosh, it's terrible, this. Dose volume histogram, there you can see the dose to the kidney. So we're very pleased with that. She's now 3 months on and has got a complete response. So we can also concentrate the dose of radiation, and the principle is very high dose per fraction, very small and complex delivery. We do what we call a cone beam CT scan, so linear accelerators have a CT scan integrated, and we do a quick, low quality megavoltage scan before each treatment to check positioning. We treat alternate days, and it's a big dose per day, and it's complex, and often for gynecological cancer, our treatments is a re-irradiation, so we have lots of other considerations. SABR can also be ablative, hence the A bit, for other tumour sites, in particular lung, where you give double the dose per day and can cure. And this is where and it's as good as surgery, and this is maybe where there's some discussion in the lung MDT about which is best for the patient. Obviously, we have to be very careful for the dose to the normal tissues, and this is very well managed and in terms of QA. This is just an example of a groin node, which is a recurrence in a previous vulval cancer, which was also treated with radiotherapy. And you can see in the I'll do this again, the dark blue is the node, and then the sky blue is the PTV, which is 3 millimeter expansion. But you could also, and that dose gets 30 gray with the sky blue, but we can concentrate, we can peak the dose, as on the right, to make sure that the node gets a bigger dose, and we prescribe 30 gray, but for example, here we got 34 gray to the target, and often we get better peaking. The image below, which is the dose wash, and that gives, but just look at that, because that gives an idea of the lower dose spread of radiation. Something else here. We can also concentrate the dose in something called simultaneous nodal boost during radical treatments. In fact, we can apply this to all gynecological treatments where we get a bigger dose to the node. So we treat a standard field, we boost the tumour, the say the cervix, with brachytherapy, but the involved nodes need a bigger dose too. So, recently Embrace 2 has demonstrated a 2 to 3% improvement in local control with the nodes with this technique. I've skipped a slide. No, I haven't. But we need to adapt to motion as well. So the top 3 slides demonstrate the planning CT scan, and then the lower 3 slides demonstrate this cone beam CT that we do before each fraction. On the left, we have an inoperable endometrial case, and see below where you can see the outline of the target, where the endometrium is actually getting close, is moved in relation to the bowel and the bladder. It's still within the PTV, which is the sky blue, so that's okay, but keep an eye. The middle one is a primary cervix cancer, where you can see the arrow demonstrating actually out by the 3rd fraction, the tumour starting to get a bit bigger, which is a bit of a worry, but we're certainly watching it within the target, but we could keep an eye. It actually settled down by the following week. And then on the right, we can see a primary cervical cancer with some hydrometria, which obviously resolved with treatment. Spotted this roundabout in the middle of week 4, so we actually replanned this and turned it around in about 3 days. And so for her last week of her treatment, we managed to reduce the treatment field. So we were avoiding this bowel in the treatment field. So this is on the right is sort of day-to-day online adjustment. It's not planning. Which you left on the right. Sorry, this is what we call offline planning and replanning. But we want to replan on the day with the best vision of what you can see. So and this is an example of why it's great to be able to see the tumour and actually see how everything around it changes in position, and in comparison to the XVI, the normal, the cone beam CT on the right, where sometimes you really can't see anything. So this is where we've got used the MR Linac, which is linear accelerator with an MR scan and a treatment planning system. This has indications, certainly, and is well used in gynecological cancer for nodal and local recurrence with stereotactic approach, definitely for reirradiation, because you can see it and replan it each treatment. Certainly a boost with brachytherapy, and Gemma Minowicz has a couple of posters about this outside. So this is becoming more widely available. We thought, why can't we do this with cervix? So limitations, it has to be node negative, and the length of time on the treatment couch. We've treated 5 patients over about 3 years and have had a complete response for all. Briefly, this is the workflow, so we can have setup, we do an image, which is a 2-minute MR scan. The computer software puts the contours that we've put on the treatment plan onto that image for the day. We then we assess the contours and edit where appropriate. That was quite a learning curve there. Physicists replan it, and then that's checked. And then we do another scan because it's 40 minutes later. We hope the bowel hasn't moved. We are expecting the bladder to have filled, and then we recheck it and treat. This is our first patient of there's a summation of all of the treatments per week. It's still over an hour, and we only gained about 8 minutes. Well, it's less than 8 minutes. Basically, that was because we learned by the 4th week, we realised we're the grey, the clinician recontouring is the grey bar. We learned that we really had to be pragmatic. It was an interesting exercise. But this is time consuming, not just for the patient for an hour on the bed on an MR Linac, but also for lots of physicists, radiographers, and clinicians. So how about doing this on CT scan? Exactly the same principle, but the radiographers are used to this. It's much more available. It is more expensive. There are some centres which have it. Ours is currently being installed. But I'm told that it reduces the treatment time to about, or on bed time, about half an hour. So it's half the length of time on the MR, but still twice as long on and for a normal cervical treatment. So proton beams. What are proton beams? So if you remember physics days, you have nucleus with protons and neutrons, and then electrons sort of orbiting around. Photons is what we normally use for radiotherapy, and they're basically a quantum, it's a lump of energy as part of the electromagnetic field and the ionizing radiation part of the spectrum, and they have different dose delivery. So if you, basically you can see the photon beam which delivers the beam as it passes through the patient, whereas protons charge through and then dump all the dose in one place, kind of part of their characteristic. We can lengthen the dose, that the area that the proton beam delivers that dose with different energies of protons, which means that we can then, you can get it over a few centimetres, and then you can fit a tumour in, and then suddenly this is interesting. Protons for other tumour types are very well established, not so much yet in gynecological. There's a lot of planning studies which is demonstrating inevitably benefit in terms of reducing the dose to the organs at risk, and this is confirmed on these planning studies. There are other sort of situations where we think there would be a niche for it, in particular reducing normal tissue sensitivity, say, for example, inflammatory bowel disease or indeed bone marrow disease. And I have just a quick case to show you. I had a case with myelodysplasia and recurrent serious endometrial cancer with node-positive disease. Hematologist said, you're not treating this woman with chemotherapy or radiotherapy. She said, why? Are you going to leave me with nothing? So we treated, I got the commissioner's approval, and we managed to treat her. So the bone dose on normal BMAT plan was 25 gray. With bone-sparing technique, BMAT 20 gray. Proton beam plan, 10 gray. Halfway through, we watched her very carefully. So I planned her with the image on the left. And we watched her, and you can see when we got down to a steady decline of platelets and white count, got to 52 platelet count halfway through the treatment. I thought, I'm a bit worried. So I asked if we could remove the elective field, so just focus on the nodes with a boost on the middle, on the right. And they said, yeah, of course we can. And so the next day, we treated for just the nodal boost, and with that, the total dose was only 2.3 gray to the bones. And you can see her counts settle down. So Yes, we can be very precise with radiotherapy, and there's been lots of work so far. There's a lot more work to be done in terms of the tumour, but probably normal tissue microenvironment, brachytherapy improvements as I've described, external beam improvements as I've described. We have loads of technology that is helping us, and sometimes you just need something bigger, sometimes you need to be really precise, but actually I think really what we need is a very clever physicist and engineer with the right sword and a very big computer, probably with lots of AI capability. Thank you very much.
Thank you very much for that presentation. We'll come to questions at the end. So next, we move back to ovarian cancer, and I would like to invite Patricia Roxburgh, Professor of Oncology at the University of Glasgow, to talk to us about novel therapeutic strategies in ovarian cancer.
Okay, hi everyone. Thank you very much for inviting me to speak today. I'm going to talk about systemic treatments in ovarian cancer and what is on the horizon and hopefully going to be the next raft of new transformative cancer therapies. So my conflicts of interest are here. So just to focus us all, I'm going to talk about specifically epithelial ovarian cancer. Yesterday, Rowan talked about the rarer subtypes, so this is going to focus on high-grade serous specifically. And obviously in this session, we've had a good introduction to what high-grade serous is. In general, it is P53 mutations are ubiquitous. There aren't that very many other mutations, actually, relative to other cancers, but there are some very important ones, namely BRCA1 and BRCA2, and obviously we've really harnessed that knowledge to improve cancer therapy. This is a picture really based on the old-fashioned, probably clinically useful small panels of NGS, but obviously technology's moved on a great deal, and now we have whole genome sequencing, although not in the clinical space everywhere at the moment. And this is a study where we did whole genome sequencing of more than 100 Scottish ovarian cancer patients and combined that with the data sets actually which were already mentioned previously in the first talk and uniformly process them together. The point of showing this really is that there is clinical utility for whole genome sequencing, although I know we don't really have it right now and it's probably too much for prime time at the moment, but it shows us the structural diversity. So this is not a disease where we can find a single driver and target it, but rather it's a genomic mess. So we've got copy number changes, structural changes. We know that about half have homologous recombination deficiency and another half have whole genome duplication. And actually those two types, they're not mutually exclusive, but they really segregate from each other in the most part. So that's something we don't totally understand very well. So it's based on this, I suppose, the BRCA-ness and the homologous recombination deficiency that we know that platinum really is our gold standard treatment. And this is a picture I'm sure you've seen many times before. And what it shows us is the beginning of treating advanced high-grade serous ovarian cancer is the combination of platinum-based chemo and surgery. Tumour volume decreases for most patients, 75 to 80% of patients, and patients feel better. So no matter what happens later, patients can really feel better, which is obviously fabulous. And then after that, we have had the addition of maintenance therapies now. So the first targeted therapy was bevacizumab, and then now we obviously have PARP inhibitors as well. What that means is patients are on treatment for longer. So it has changed what life looks like for patients. They don't get to necessarily have a time off treatment. So they're always thinking, I have cancer, I'm on treatment all the time, I see oncologists frequently, but we know that the PARP inhibitors really bring value, and we've got lots of randomised studies telling us this is the right thing to do for many patients. We do, however, sometimes forget that we do have that 20% of patients where actually we're not serving them well, and they are patients who in general are excluded from a lot of experimental studies, so that's something we really need to think, is that the right thing that we're doing? Now I'm going to take a minute to explain this curve because I think it's really important, but if you're not used to looking at these, it's quite difficult to understand. So this is from the PAOLA-1 study. So that was chemotherapy with bevacizumab, followed, and then maintenance bevacizumab and olaparib versus just the maintenance bevacizumab. And this is about what happens when those patients progress. This is what this curve is telling us. So when those patients progress after having been PARP exposed, you know, does the next therapy work? That's the question. So this graph is the time from the start of the next treatment to the treatment after that. So it tells us about how effective that treatment has been. And if you look here, there's something really important happening, which is that the red line are patients who progressed during first-line olaparib. And if we look at the green line, that's patients who progress after first-line olaparib. So you can see that patients who progress on the olaparib actually do worse than those who never had any PARP inhibitor in that period of time. So it means the disease has changed. The subsequent therapy in this study wasn't dictated by the study, so we applied our old-fashioned techniques, which are, is it in that over 6-month time frame? Will we re-expose to platinum again? And what it's telling us is that that no longer works for this patient group. So we've got changing unmet needs, which are important to understand. And this is a plug for 2 very important translational studies that are happening in the UK just now. So my study, the PAIR study, the PARP inhibitor resistance study, and the BRITROC2 study. The PAIR study is still recruiting patients, and we are trying to collect samples pre and after progression on a PARP inhibitor to try and understand what is happening so that we can appropriately design therapies. And then we've got BRITROC2, which actually goes beyond that. It's finished recruiting, but patients obviously are still on study, and we need to not be missing those times when they need a repeat sample so that we are learning about the evolution through treatments. And this is specifically, obviously, PARP inhibitors now, but when these new treatments come, the same problems will arise. We need to understand what has happened to the tumour as a result of what we did with the treatment. Okay, so now on to the novel strategies. I've divided them into 4 rough groups. So first, improving on our current standard go-to for platinum-resistant disease, weekly Taxol. Antibody-drug conjugates, which you've heard about many times already. Immune modulation, and then targeting DNA damage repair, and also some synthetic lethal approaches. These are, I'm just going to very briefly, not go into much detail on any of these, but it's just to give you a flavour of what I think might be involved in the future pathway for these patients. So at the moment, when we see a patient with platinum-resistant ovarian cancer, I think the first thing is to think, are there any trials? It's always the first question. But if we look at what we've learned from trying to improve paclitaxel through many different randomised studies in the past, what we can see is very consistently the control arm gives us a response rate approaching 30%. So that's really useful information. Almost none of those actually improve things, the experimental strategies, except bevacizumab. And so the combination of weekly Taxol and bevacizumab is definitely a very useful one, available in Scotland but not in England. And then to be fair to everyone, it is a subgroup analysis of this study that I've picked up rather than the whole study. So that's where we're starting from. And things are really improving. So it's great to be able to stand up here and say we've seen some overall survival advantage of some new therapies in ovarian cancer. This is a first. This has happened in the last year. And so the Rosella study. So this study was looking at inhibiting glucocorticoid signalling. So glucocorticoid signalling it inhibits the apoptotic pathways, so the cell death pathways that you need to be working in order for a cancer cell to die in response to chemotherapy. So we want to take off the brakes by inhibiting glucocorticoid receptor. So that's what this study was testing. So patients with platinum-resistant ovarian cancer randomised to have either nab-paclitaxel or the glucocorticoid receptor antagonist with nab-paclitaxel. And just to explain about nab-paclitaxel is like paclitaxel, except that it doesn't require the steroid pre-medications that we require when we give weekly paclitaxel, and clearly there would be no sense in inhibiting and giving steroids at the same time. So that's why it has that design. And here, so presented at ASCO and then published in The Lancet, are some lovely Kaplan-Meier curves. So the progression-free survival, you know, it's a small benefit, but the overall survival benefit is actually 4 or nearly 5 months. So it's a big change. We've not really seen this. And also, I suppose to me, the importance of this is that it identifies a new pathway, which is actually relatively understudied. And it feels like with more translational understanding, we really could identify patients where this is a real quite a game changer. So I think this has opened the door to lots more research and lots bigger benefits, and benefits that we've not seen in this group before. So it's very, very important. And then if we go back to my table and I pick out one of the other studies, so this is an AXL inhibitor study, so weekly paclitaxel versus weekly paclitaxel with the AXL inhibitor. The idea there is, again, that the AXL inhibitor will turn on or take the brakes off the apoptotic pathway, so cells can die with chemotherapy. And although the study was negative, with some translational research and taking out the group that have AXL high, you can see that again we start to see benefits. So I suppose what I'm saying here is it's important not just to be like, well, that didn't work, let's move on, but rather, why did it not work? Is there a group it did work in? And to maximise, the data and the samples, the inconvenience that patients went to participate, to make sure we learn as much as possible, I think is our job. Okay, so I'm going to go on to strategy 2. And antibody-drug conjugates have been mentioned many times, and obviously people here treat gynecological cancer, so in reality we do have them that are coming, so just to make sure everybody understands what specifically they are. So we've got an antibody with a linker and a payload. So essentially we're trying to deliver chemotherapy to cancer cells specifically in a more precise way. And so, as you can imagine, there's lots of different iterations of what the antibody could detect and what the payload could be. And so there is an overwhelming number of different antibody-drug conjugates in development. And Susie Banerjee presented to you the Midasol study yesterday. So a second study with a survival advantage in platinum-resistant ovarian cancer. So that is really, really so important. So with mirvetuximab, we've got a tubulin inhibitor, and the antibody detects folate receptor alpha. And 35% of patients had an improvement in PFS, 33 OS, and an ORR improved to 42%. I suppose one thing to just point out about this is it took a really long time to get there with this drug, and that was because we had to get the folate receptor alpha assay right. So spending that time to understand the assay and the biomarker is of paramount importance. Okay, and this is not the end of the folate receptor alpha story. So these are other folate receptor alpha antibodies with different designs, with different chemotherapies. And these two graphs at the bottom here are just a couple of examples of the types of response rates we're seeing. So 40% is what we see, and we would really not have expected that before, up to 50%. And the graph with the various shades of blue, what they're doing there in the early phase dose finding part is they're starting to try to dissect. So the blue indicates different levels of folate receptor alpha expression. So at the early stages of development, they're trying to layer on immediately does that matter? For some antibody-drug conjugates, it might not matter, and for some, like mirvetuximab, it really does matter, and you want to know that as early as you can. Okay, I'm going to move on swiftly. So this is just to show you, it's a very complicated picture, but the point is, the top box is just like the antigens, the cancer-associated antigens we know about, so that's all opportunity to design new drugs targeting those antigens. So there are many is the point. And then this new drug, so I'm just giving you a flavour of one that detects a different antigen. So this detects the CDH6, and it's attached to a topoisomerase 1 chemotherapy. And this has very promising response rates, as you can see. And now the REJOICE study is underway, which hopefully will show that this is also another effective option. So I'll just leave antibody-drug conjugates there in the interest of time. So immune modulation. So we've had a bit of an introduction to that already as well. And we know for a long time that high-grade serous tumours with TILs infiltrating, those patients survive longer. So it would follow that immunotherapy should work. We do, however, know that those drugs, the checkpoint inhibitors, which have been useful in endometrial and cervical cancer, do not work in ovarian cancer, certainly in the places we've tested them so far and have been published. So there's been many first-line studies, all which have not shown that as a useful strategy. So we need novel strategies, and these are just two to mention to you. So the first one is a bispecific antibody detecting CD3 and MUC16, also known as CA125, and essentially it's bringing the immune system to the cancer cell and saying, help recognise me, and please, get rid of me. And the other one is, it's actually not quite a bispecific antibody, but it's an engineered T-cell receptor which detects PRAME, which is expressed on the cancer cell, and then engages with CD3. And so you'll see with both of these, we don't get, measuring response rates is not the right thing for these drugs, and actually it's more about the duration of response. So you can see, although these lines aren't going down mostly, some of them are going out very long, so getting long control. And in general, after initial infusion-related reactions, these are well-tolerated drugs, so they might find a space in maintenance. So it's definitely important to keep developing these. I'm going to finish with the fourth strategy, which is DNA damage repair. So this is obviously complex and shows the main methods a cell has, mechanisms to repair DNA damage. A cell needs these. And obviously we've already exploited BRCA, and many other ones have been tried. WEE1, ATR inhibitors, and there's definitely hints that they work. The scheduling's tricky, and the toxicity is definitely an issue which needs to be managed, so hematological and GI toxicity. This is just a sample of various ATR inhibitor studies. There are many, 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 but just to highlight a few, this one I'm highlighting because it's one of the early studies which is starting to dissect out this idea of post-PARP having finished PARP or post-PARP progressing on PARP being different entities. So I think it's important we start to do that going forward, so that's why I'm pointing out that one. This one is about targeting cyclin E amplified tumours, and cyclin E amplification maybe about 30% of cases. And this study, the MYTHIC study, has shown a 45% progression-free at 24 months. This is a combination of a PKMYT1 and ATR inhibitor. And the reason this combination makes sense is because PKMYT1 puts the brakes on a cell entering the cell cycle so that DNA damage can occur. But when you want the cell to die, you want to take off that brake and let it go into the cell cycle. So that's why this combination makes sense. And actually, FDA have granted fast-track drug designation to this on the basis of this data. So hopefully things will get to move forward with this combination. Also sticking with cyclin E amplification, we have these data which were published in ASCO just this year. And this is looking at cyclin E amplification, amplified tumours, and given CDK2 inhibition. And so that makes sense because when you have cyclin E amplification, you inappropriately are inhibiting RB, which means you have a lot of go translational activity. So you want to release that, and you can do that with the CDK2 inhibitor. This is very well tolerated. Response rate around 35%. But what's really interesting is that of those responders, 11 of them had cyclin E overexpression. So I think it's hinting toward a very good biomarker. I'm out of time, but I've only one other thing to tell you about. And it's another synthetic lethal strategy. So we need pyrimidines in order for a cell to survive. And this CTPS1 and CPTS2 need to work together in order for us to have pyrimidine synthesis. But we know in ovarian cancer, high-grade serous, about 20% have lost CTPS2. So in that context, when we give an inhibitor of CTPS1, the cells, cancer cells should die while the normal cells are safe. So this is similar. It's a synthetic lethal story like PARP inhibitors. It's in early clinical studies, so in terms of efficacy, we do not know yet. It's very well tolerated so far. So here are my headlines. So I guess the first thing is that PARP inhibitors have really changed what we're dealing with now, so we need to fully appreciate that. We have to understand our tumour biology better, and we have to support these translational studies where we're getting biopsies and we're planning that. How does this make the cancer biology change every time we introduce a new therapy? So really important. The strategies to watch that will come are glucocorticoid receptor inhibition, antibody drug conjugates, and our problem will be having too many and how to sequence them and how to make them work together. The more novel immunotherapies, so these T-cell engagers and bispecific antibodies, so we'll need to all be proficient at managing cytokine release syndrome. And then we have the synthetic lethal and DDR strategies. So really good to have some options for the cyclin E amplified tumours because they're a poor prognostic group, so that is fabulous. And then a synthetic lethal option where with the CTPS1 inhibition, also super to have something that really should spare normal cells. So that's I'll whistle stop to it. I have not covered everything, but that's just a select few. So thank you very much.
Thank you.
Next, I'm going to invite Professor Mara Kirgir from Imperial College London and she's going to talk about a novel trial for our novel strategies. Thank you.
Thank you very much, Mina. Come and sit down. So our next speaker, last speaker from this session, is Professor Somashkar SP from India, who is going to talk to us about HIPEC and PIPEC, current evidence and future directions in ovarian cancer surgery.
Thank you very much, and it's an honor to be here. Thanks to Ranjit and the organizing team of BGCS. So there's going to be a combined work of my large team. We are a team of about 6 consultants who keep doing CRS and HIPEC and PIPEC over the last 15 years, and supported by another 20 fellows. So we do about 220 CRS HIPEC a year and over 3,000 over several years. And it's a very large referral center and teaching institution. So it's a combined work which I'm going to put and say how we integrate. There are no disclosures or conflict of interest relevant to this talk. We have cytoreductive surgery, aggressive upper abdomen surgery. Then we have heated intraperitoneal chemo, normothermic intraperitoneal chemo, EPIC, early postoperative normothermic chemo through the catheters. Then we have PIPEC and emerging recent trials on FAPI. So how do we integrate? And don't miss, in medical oncology, we have a weekly dose PACLI. Then we also have bevacizumab PARP inhibitor. So it's like a big confusion, where, how, where to sit, where is neoadjuvant, where is adjuvant. If you look back, PubMed, maximum interest in last couple of years are on the paper concerned to intraperitoneal therapy, which go on to show how important this particular therapy is and emerging data that is coming. People who want to practice ovarian CA, we all know 70% are in stage 3C or 4A, and you need to be well versed with entire abdomen, hepatobiliary, colorectal, upper abdomen, diaphragm. Now we have to enter thoracic area for cytoreduction. So there is no complaint. This is a norm, you get it every day if you are operating advanced CA ovary. Never to call this inoperable. Put a good effort with 2 to 3 team. Spend enough time with your skill. And this is not a surgery you should do if you have a movie or a dinner planned. Remember, the life of the lady is the effort you put inside until you put the last stitch. So most of the time, quite often, 76 to 91%, depending on where you practice, the rescue mechanism and the system, actually you can do optimal cytoreduction. This is a beautiful slide I borrowed from GOG and ESCO, which showed ever since single, doublets, PACLI, and then bevacizumab, PARP inhibitor, how the survival grew from 24 to 110 months. Did this happen just because of our medical onco colleague? No. The same curve, if concomitantly the gynae onco community had not improved their surgical skill into upper abdomen, reduced morbidity, mortality, sent the patient on time to a medical onco within the golden period of 2 to 3 weeks for the first adjuvant, and learned how to achieve the CC0 boundaries from 30% to 90%, we wouldn't have been able to achieve. The curve with medical onco and gynae onco, and without development of advanced surgical technique in gynae, you can see still would have been stuck at 30 months. Now we have 3 modalities available for advanced ovarian CA. The irony is every solid tumor we speak in terms of 5-year survival. Come ovary, suddenly everybody stops speaking 5 years. It's all in months, 36 months, 40 months, 60 months. Why? A disease which is surface. Rarely women die with extra-abdominal disease. Cause of death is peritoneal recurrence, cancer, cachexia, intractable ascites, obstruction. And highly chemosensitive, multiple lines available, yet 5-year survival is dismal. Even in the new trial of Scorpio trial, it doesn't matter you give NACT and operate, or you operate upfront and then give the chemo. You can look back, 15 months PFS, 41 months survival. Extremely poor, in spite of more than 40-50% of patients taking bevacizumab and PARP inhibitor, yet this is where we are. So is that the best we should practice? The second irony, we always ask for evidence-based medicine. What better evidence than IP port-based chemo? So we know that 7 randomized trial, only 1 negative trial, showed a huge survival, Deborah Armstrong trial and Maury Markman study. And we all know that this is a very good forest plot which showed a significant survival, which had a diamond there, and the only one of the few studies which showed 100 months survival. 100 months. The only 2 trials in the history of ovarian CA which showed 100 months. Japanese dose-dense Paclitaxel, which not many people practice, and then the intraperitoneal port-based chemo. Yet we don't practice that. We looked at in India and we published a large amount of study in a country like ours, where patients come from various cross-section, and yet it is not common to practice because catheter-related problem, difficulty, acceptability to call the patient twice is not. So the option 3, you do a good cytoreduction, upper abdomen, pelvis, then you add a heated intraperitoneal chemo, so the chemo concentration in the peritoneal cavity and the heat actually improves. This is a beautiful paper. I request anybody who are interested in a HIPEC to understand the various mechanism. So now we look at where does the HIPEC integrate. Upfront, no RCT. OV HIPEC 2 is going on, and ours is a center through Colgo, which we are doing. But there is a subgroup analysis from Korean study which showed a survival benefit. And then we have a large evidence from Indian HIPEC cancer registry which was presented. In interval, we have 3 trials, and in recurrent setting, we have 3 RCTs. And we have 2 very large meta-analysis which showed significant benefit both in DFS as well as OS. And yet, it is not very, very well practiced. We know in OV HIPEC 1, a updated analysis of 10 years showed benefit across all the group, and the peritoneal recurrences were significantly less because in ovarian CA, in-house peritoneal recurrence and obstruction-free survival is most important factor for us to do. Of course, we have one of the trial from MSKCC which showed carboplatin with HIPEC is not a good molecule and it is a negative trial, so we have to go back to cisplatin. Now coming to recurrent, so we know that scoliosis trial showed, it's a prospective phase 3 RCT, showed a benefit in both platinum sensitive and resistant with a significant benefit. And now our French colleagues brought the SHIPAR trial which showed in recurrent ovarian platinum sensitive, finish all the chemo, come back to HIPEC, and there is a statistical significant survival. These are the 2 recent huge meta-analyses which showed integrating intraperitoneal therapy is good. This is a study which we presented in ASCO from Indian HIPEC registry of 1,470 patients undergoing CRS HIPEC, and it showed the patient who had upfront surgery with HIPEC had the best survival, and this is there available for you to read. The beauty of this study which we present from India is some form of intraperitoneal therapy, preferably 4 to 6 port-based chemo with good surgery was beneficial than a HIPEC to do that. The message is some form of intraperitoneal therapy is better. If you can't practice 6 cycle of port-based, this is the second best. We also had an evidence which we presented, this is published in this journal. If for some reason advanced surgery patient had morbidity and they don't go on time for first chemo, because we know every week after 2 to 3 weeks delay happens, we lose 1 month of survival. There is an evidence already available from Korean group and Japan. We showed that if a HIPEC with a dose of chemo is there, this delay up to 40 days didn't matter, showing that there is something happening with that heat and HIPEC. In this era of bevacizumab, PARP inhibitor, do we still have a role of intraperitoneal therapy? Yes, there are the 2 beautiful evidence also discussed in Chicago consensus, showing very well, even in spite of these 2 molecules, there is a good effort to reach it. This is a beautiful slide. What it takes to achieve better for these women, which is the most cheap, easiest way. HIPEC the cost, bevacizumab, PARP. So it's important to understand good surgery with some form of intraperitoneal therapy would be the most economical way to achieve a good survival. Now coming to see the second technology, PIPAC, we know that the PICOS trial has already started in UK and it's going on in 2 centers, role of PIPAC in ovary. We all know that it's a high-dose intraperitoneal aerosol-based chemo. Currently, its role is in second and third line in platinum-resistant, platinum-sensitive, and neoadjuvants. So we have a 2 large study. We have published, we have do about 300 PIPACs, and it is a referral center. And you can go back and read the papers we have published and the meta-analysis which came out, which showed even in third line recurrent, there is a response rate of 60%. The first ever randomized controlled trial in platinum-resistant ovarian CA was done by our group, which is an Indian RCT. You can read that Google. And we found that the response to first, second, third PIPAC, and you can see the last CT would almost be passed as a normal CT scan if you don't give a history. We published and showed that the response rate combining IV chemo alone versus a PIPAC was significantly better, 69%. and quality of life was well preserved and better as per the global index, which is available to be read. So the results were histological regression, clinical improvement, quality of life, better response rate in comparison to IV chemo was superior in the PIPAC arm, and an extended dose-dense regime was presented in IGCS for us. Now we have moved our clinical trials into neoadjuvant. What do we do that in spite of the best IV neoadjuvant chemo, patients are not amenable for optimal cytoreduction? So we started a study at our center. Those patients who are not amenable for resectability yet after optimal neoadjuvant chemo, so do a neoadjuvant PIPAC in this particular group, and then to go and see how they can be converted into curative. In ovarian CA, if you don't operate them and achieve an optimal cytoreduction, unlikely ever to even see 5-year or a cure. So this is a study which we took, it's a single arm study before we plan to do an RCT. Those patients not responding to chemo, not taking optimal chemo, there is no response and they persistent remain to be non-resectable. So 45 patients out of 28. I'll not bore you because of want of time. This is the paper. 62% of these patients with neoadjuvant 2 doses of PIPAC with concomitant IV became resectable and amenable for CC0. So we converted the path from palliation to an option. And this is presented in ASCO, and then JCO abstract is available. In the last 2 to 3 minutes, I will say the new study which we are doing at our place. How to modify the microenvironment of ovarian CA, convert them from platinum resistant to platinum sensitive, and when 3-4 lines fail, how can we still have a ray of hope? At India, you know that it's a very big country, 1.4 billion population. In my center, we have 2 FAPI therapy units. So we do about 19,344 FAPI scans and then over 300 therapies. So it changes the microenvironment. You do the IV high dose of FAPI therapy, nuclear medicine, and we found these studies that those patients who don't respond to any further treatment, PARP or bevacizumab or multiple line of metronomic chemo, we found that by giving FAPI, re-challenging with cisplatin, the microenvironment is changed and they become more sensitive. And at that level, when they would almost die in couple of days, survival was improved by 8 months. And we started observing this phenomenal response, and this is published from our group. Patient on day 1, second FAPI therapy, almost the scan looks normal, and then CA125 dropped down significantly. So when we analyzed this single arm study, we could find that even in third line when nothing is acting, there was a complete response in 4%, partial response of 45%, and stable of 12%, and progressed in 39%, with a significant added survival benefit. This is available to be published. We have published in the Journal of Nuclear Medicine. And recently we presented it in ASCO, coming ASCO, and from our group, how FAPI therapy in advanced ovarian CA at significant line can be used. Because of that, we tied up with ASIMA into the COLGO and ICMR. Along with that, we started multiple prospective trials. So we are going to launch these. So one is called as FAPI-ROC, FAPI in platinum resistant, how it can be used. The NEO-PIPAC, multicentric, prospective, multi-institution, multi-country studies, where through the Indian Society of Peritoneal Surface Malignancy and Gynae-Onco, how we can manipulate the microenvironment and we can do. And most of you are very welcome to get in touch with ASIMA. So through this GCIG, how we will be planning to roll out these prospective randomized controlled trials. So in conclusion, I want to let you know, you can take a CA ovary, do not a great surgery, end up with recurrence in 6 months, platinum resistant, Aurelia trial, chemo, and then bevacizumab, most of them dead very fast by 2 to 3 years. Or analyze the patient rightfully, do a good surgery with some form of intraperitoneal therapy, then they're all pushed, leaving the biology ahead into platinum sensitive. Then we know today in a patient who has less peritoneal recurrence, and obstruction-free survival fit enough to take multiple line of chemo, and when they recur platinum-sensitive 2 to 3 line chemo, then add PIPAC, keep a clinical trial option of FAPI, and we can cross 60 months. So it's for us to understand how to do that. So these are the 4 RCTs positive available in ovarian CA. We need to learn how to do this surgery. This was a chapter I authored for FIGO, essential skill a gynec-onco should possess, and I put all the 3. You can Google and read this. So what are the take-home message? HIPEC in interval setting, we have a good study. We are a part of OV HIPEC 2. We will wait for upfront when the OV HIPEC 2 comes. Recurrent setting, already 2 trials are there. PIPAC in will wait for UK study because so our trial is the only RCT which is presented, and it's very well documented in platinum resistant. Neoadjuvant inoperable rather than palliative, subject them to PIPAC and then look at it. We'll wait for a prospective RCT from our group. FAPI therapy is experimental, beautiful study happening with us. But remember, a bad cytoreductive surgery can never be compensated by a very good HIPEC. Don't be under that. Most important prognostic marker of all the prognostic today is still aggressive gynae-onco with an option of research. So at our trial, we have a very large number. We have a lot of fellows visiting, and we have a funding for about 6 fellows who are coming from international. We have a tie-up with Basingstoke. We get 4 fellows, and then a lot of research, clinical trial. And I request all of you to be part of this randomized controlled trial with us and discuss with Asima. Thank you. And that is my lovely second daughter who looks like a Rapunzel, and my lovely family. Thank you.
Thank you very much indeed. That's great. Now, and thank you for all keeping so well to time. We now have some time for questions, discussions. Please come to the microphone.
Thank you for really fascinating and cutting-edge work. My question is to Professor Kyriakou. So I had a question about timing of the vaccine. So you get the novel trial and the Netherlands trial are giving it at the time of the LETs. So my question to you is there any capacity, because obviously this is a question that's asked routinely when we're colonizing women, is there any capacity for offering a vaccine at the test of cure smear when they are HPV persistent? Is there any work on that, or do you have any insight into that?
To give the vaccine 6 months after?
Yeah, that's what I'm saying. So would there be any change, perhaps, in the way that a patient responds to the vaccine?
I suspect it will be worse, because if we assume that some people clear the virus at the time of treatment and then they get reinfected by their partner, if you delay it until 6 months, I can't see any benefit. Okay. I guess the question is, if you were to give it a bit before treatment, whether there would be any benefit. And a few people have done studies like this, but they were too small to show any difference. And the reality is that in real-life clinical scenarios, you can only give it at that point, because people, based on the timelines of the NHS, are referred within 2 weeks with a high-grade smear and then have to be treated. So I don't think there's any other clinically relevant point. The sooner the better, because you need at least 30 days to get some antibody response. People don't have sexual intercourse for about 4 to 6 weeks after treatment, and therefore you're potentially protecting them. That was the theory. The practice is that we've not seen any of this in the data, really. I think 6 months later it's going to be even worse.
So then the next question is, obviously there's a lot of work, we have a company that's helping us with this PapilloCare. What's your view about that, about using that either for low grade or for women post colonization?
I think all of these supplements and preparations have very small evidence base. I mean, they're not drugs, so they don't go through the process of drug trials, and therefore I don't think anybody can recommend this products, but they're there. They're likely not causing any harm. And if you think that on the basis of the data that has been published, you feel that this is sufficient to try it and spend the money that you need to spend to purchase this, it's an individual choice, but it's not something that I think is routinely recommended or in any of the guidelines. But there are products there are loads of probiotics, prebiotics.
Yeah, for sure.
All sorts of things claiming. And I think women with HPV infections are particularly vulnerable in trying all of these preparations, because they feel they have an infection that there's nothing they can do about, yet the social media is bombarding with all these products that are out there. Which have quite limited evidence base. So I don't think I would actively encourage people. I wouldn't discourage them, but it's not something that I could go and say, look, this is shown in trials that it works X and Y. But there is some data. I think the company you mentioned has produced some studies that show a benefit. So on the basis of this data, if people wish to trial that, then absolutely yes, but it's not drug trials that have gone through approval to show a drug effect. So, but many times in medicine, things predate the evidence. So, yeah.
Thank you. I think we've got a queue building up there. So, please.
Great. Many thanks, Ahmed, for your very inspiring talk. I like your methodological and detailed approach. One question I have is, if you look at the fimbrial fallopian tube cells and you put this in correlation with the prevalence of the disease, ovarian cancer, then obviously the fimbrial cells are probably those cells which have by far the highest risk of becoming cancerous in the human body. And so this is a bit odd, because these cells don't proliferate a lot. Why should they? So in this respect, there must be a cell non-autonomous component which puts these cells at risk. And I think it's the close proximity to the hormone-producing organ, which is the ovary. And here it's probably progesterone, which works as an immune suppressive environment, and reducing the cytotoxicity of natural killer cells, increasing B7H4, etc. So the question is, if you implement a vaccine, would you likewise also reduce the progesterone activity by combining the vaccine with mifepristone, for instance, which we are trying to do for breast cancer and BRCA1 mutation carriers, because we've seen in BRCA mutation carriers there's a much higher level of progesterone, in particular in the luteal phase.
Yes, thank you, Martin. I love the question. We're trying to understand this in doing the knockout models. So we have developed P53, BRCA, P10 individually and in combinations directly in fallopian tube cells and organoids, and we do see that progesterone have a profound effect. I mean, this is preliminary data; we haven't published it yet, but it's certainly something that I'm considering and thinking about. So. Yeah, great question. Thank you.
Thanks.
Ranjit, yeah.
Thank you. Great talks, everyone. Thank you. Question for Ahmed. Maybe a bit speculative, or just your thinking around where do you think the vaccine is going to act in that continuum? Where is it going to be most effective, whether you're going from a pre-stick, stick, micro-invasive, or for that matter, beyond phase? Do you think it'll be gradation? And then, of course, it's got applicability beyond that. Do you see things coming in, where in that continuum do you see it acting? Do you think you may need more than one dose? Just loads of questions. And where do you think it may be more effective, especially also conditioned by what Mara just presented?
Yeah.
So.
Yes, I think that's... I personally think that the earlier we give the vaccine, the better, because that's the highest chance, from my own perspective, is to try to deal with these cells as they transform, rather than to wait until they form a stick. So I think that the most effective period is pre-stick formation at the time of induction of mutations.
Do you think they may work on stick?
Yes, I believe. I mean, I believe so. At least they will maybe reduce the size of the sticks, but perhaps not eliminate them completely. We'll see.
Thank you. Yeah, another question.
Thank you so much for an amazing set of talks. I had a question for Prof. Ahmed, which was, in terms of the peptides that you're isolating, you may have mentioned it, but what stage of ovarian cancer are the patients that you're getting? And the reason behind the question is the peptide profile, I assume, of stage 3 progressed ovarian cancer with an established tumor microenvironment and lots of mutations potentially may be significantly different from the peptide profile of stick, where you're anticipating these T cells to activate, or it may not be. Just wondering your thoughts.
Yes, so the ones that we are working on at the moment are ones that we believe exist in both. So we would hopefully be able to tackle the precancerous lesions.
Thank you very much. Thank you.
Hi. Thank you, everybody, for your lovely talks. My question goes to Professor Somshekhar. In your series of PIPEC, especially those patients who had neoadjuvant chemotherapy and then you went on to do PIPEC, were there any of the patients who had complications while doing the laparoscopy, like bowel perforation, that didn't delay the chemotherapy? Because one of the things is, I mean, these patients sometimes have extensive disease which you can't see on the CT scan.
Thank you for the question. Actually, this has been answered in the international PIPEC registry. You know that in Lancet, we published 14,000 PIPECs across the world. We do about 300 a year. There is a significant learning curve in laparoscopy because most of these patients have multiple surgeries, scar, and recurrent disease and plastered abdomen. But there are very good modules we have published through the ISSP, the International Society of Pleura, how to access. Once you finish the learning curve of 20 and 30, the bowel perforation rates are less than 0.4%, and mortality is close to 0.001%, and it's not because of the technique. So in my series, which we had an interim analysis of around 190 patients on either side, we didn't have any bowel perforation, and no delay in the chemo arm, also patient going into chemo. And conversion, there was no complication. In fact, after PIPEC, it's quite safe. Now we are just publishing 2 manuscripts. Bevacizumab combination and PIPEC is not contraindicated. Both can go concomitant. PIPEC and IV chemo, we deliver on the same day or the next day in same admission. So after the learning curve, it's good. I'll be interested to know the UK study because, and I'm sure the results are pretty much the same as ours. Thank you.
Perhaps I could just follow another question on that, because conceptually I've always found it very difficult to understand the depth of penetration of the drugs that you're giving either by PIPEC or even by HIPEC, because what we know is that these drugs tend to penetrate only 1 or 2 millimeters into the tumor. So how is it working, for example, in the neoadjuvant setting when you're adding PIPEC? Do you have any idea how deeply the drugs get into the system?
Yeah, this has been extremely well researched both in lab, phase 2, and in human model with fluorescence study and the depth. HIPEC, intraperitoneal chemo without heat is about roughly 5 millimeter, 2 to 3 layer. There is a lot of evidence. Once you add heat, it goes up to 7 millimeter. But with the PIPEC, it goes up to 10 millimeter. And now there is a new technique called e-PIPEC. So we just put an electrode and we charge electronic PIPEC. And that crosses 12 millimeter. So I don't still practice e-PIPEC, but Mark Raymond in Germany has a large amount of publications. IP chemo with heat, pressure PIPEC, we can touch more than 11 to 12 millimeter, which is okay for ovary, not for other peritoneal surface.
Okay. Another question.
Thank you. This is a question for Lisa about radiotherapy. It's a bit of a basic question. What proportion of your brachytherapies do you find difficult to insert? Partly because, that's an issue that we know that brachytherapy improves survival in those patients, and if it fails to be entered or put in the right place, and that's a survival deficit in essence. Do you ever use hysteroscopically guided insertion? Because that's what we've done in our centre, and that's allowed patients who may have not had the brachytherapy inserted to have the brachytherapy probes inserted. What are your thoughts on that, and how do you implement it in other centres or get that widely implemented?
Yes, absolutely. I'm aware of this. Some centres having gynecologists to help with the insertion. In fact, they do the insertion. We would have the opportunity to do that because we work with gynecologists in the same hospital, but up to now we've not needed to sort of ask for help. Very occasionally we can't get the applicator in, but it's pretty unusual, and I'm trying to think of the last time I've not. I would say we've had some bad insertions, but we tend just to sort of either try again or look for an alternative. But it's.
I think in our centre we've had cases where the oncologists haven't been able to put it in, and they operate on the same morning as me.
Yeah.
And so in those cases, I'll relist
You're next door.
and relist them or ask for help, and that's actually helped. But I think that's an approach that I think should be considered.
I think centres are struggling. I mean, the other thing to say is that we all use ultrasound. Well, we use ultrasound guidance, sort of transabdominal ultrasound guidance during the brachytherapy, which is very helpful in terms of guiding where you can put pressure in terms of applicator insertion to check that you're heading and pushing in the right direction where you've got cervical stenosis, which is common. So we find ultrasound really, really helpful, and I think that's made a massive difference.
We've got one last question, I think, before lunch.
Thank you, everyone, for presenting tremendous work. I have a question for Professor Ahmed. You mentioned about recruiting 40 ovarian cancer patients. I was just wondering, do those patients, do they have a specific tumor subtype according to the Oxford Classic characterization system, or is it just patients who have a high EMT subtype?
They're all patients with serous cancers. Those are the ones we are recruiting at the moment.
Okay. Thank you.
Okay, so with this, I think we close this session, and thank you, everybody, for joining us. Thank you.
Thank you.